Okay, thanks very much, Andrea. And sorry you got me again, but yeah. So I just put this one up again, not really to sorry, repeat what I said before, but just to point out that each of these academic institutions, so the NCD grant was awarded to the academic institutions, but each of those institutions had its own sort of sister NHS trust, effectively. And so for all of us, there's right from the get-go, there's been the question of, well, how do we interact between academia and the trusts? So here's the outline of the talk, and it will be briefer than the last one. I just want to say something about the historical and political context of the discussion we're in. And again, this is my personal take. What do we think? What are the generalities about NHS versus academia, and what has NCT been doing? So the bottom line is we've been riding two horses and trying to see which way things fall out in the end. Andrea also asked me to give you a few reflections on cloud versus on-premises storage. So I'll do that and then brief conclusion. Okay, so our situation with data and the NHS, as far as I can see, is on a bit of a journey, and it's still going. So I've been around long enough so that, you know, paper records used to get trundled around all over the place in trolleys. I think we see the trolleys a little less at the Marsden than we used to, but I still see them around. So we started off there. Gradually, we started to get text-based files. So you would get, you know, things like clinic letters go out, and they're obviously generated by computers from some little database that's attached. But you wouldn't have been able to say that that system could link to any other sorts of big data or whatever. Then we've been through, and to a certain extent, we're still in this stage where databases, we now have a large number of structured databases in our institutions. So we've got our RIS, PAC systems, laboratory information systems. We've got lots of genomics data sitting in different pots. We've got digital pathology sitting over here. But again, none of these things necessarily link up completely with each other. We just had Epic installed at our hospital, a 3-year massive project that sucked all the life out of our hospital IT department. It's very painful, but now over. Those people of other institutions have other systems installed and have had longer experience than we have, but potentially they are going to be a source of joining things together, hopefully. Then we had COVID came along, and we sort of past COVID. What COVID did, I suppose, was encourage, from a research perspective, really gave the government a boot up the backside to say, you know, we need a facility to set these things up very rapidly. And so since then, there's been a sort of really big pouring in of money into various aspects of the system. And hopefully we're on our way to getting some sort of fully integrated systems across multiple organizations, and this is where the hope for these SDEs lie. And so all this has been happening in the NHS, but it's probably true to say that the main expertise for analyzing all of these data exists and has existed within the university context. Most of the partnerships work out with the academics doing the machine learning sit not in the NHS but the university sector. So there's been a lot of expertise from a genomic point of view in big data. There's been AI development, and universities have very significant computational capacity these days. But this is all sort of changing, really, and it's set to change quite rapidly, I think, post the Goldacre review. So this, I mentioned it earlier, and other people have mentioned it, and it's a really interesting read that sets up a good framework for the sector. Now, this has been out for a couple of years, and we're starting to get the government response to this in terms of the various initiatives. But one of the main things Goldacre said was that pseudonymization is not fit for purpose. I'm not entirely sure I agree with him overall, but he reckons pseudonymization is not fit for purpose because there are too many ways to break it. Now, I'd argue that in the sort of research we do in imaging, where we tend to have, if you look at the TCIA, the Cancer Imaging Archive, they'll have a collection which is pretty much just the images and some regions of interest and stuff like that. And you don't necessarily have a mass of already linked data. What Goldacre was saying is that as soon as you start to get to the case where you are joining lots of these things up and releasing tranches of data that span multiple sectors, that's when you really have to worry about these things. And I'm very interested to hear what the views from the sort of UK Biobank point of view are, because I think some of these other data sets are much broader than our imaging ones. But anyway, this has led to this idea of trusted, first of all, trusted research environments, and then the terminology seems to be moving on to these SDEs, secure data environments. And this was sort of crystallized in October this year, just a couple of months ago, with this data access policy update from the government. And there's been really, and it's sort of just making definite that there's going to be this significant policy shift from data sharing. So, i.e., you give somebody access to a website, they download a whole load of anonymized data, and then use it as they see fit in their project, to the concept of, well, we'll let you into our portal and you can come and work on our virtual desktop, and you can only do what we let you do. And you can only output the statistics and things that we let you output. So that's it. That's a really interesting shift. But what I find fascinating, I go to conferences, this is not mirrored by my US colleagues. That you talk to them about secure data environment, they don't know what you're talking about. They know about HIPAA, and they don't really get this whole concept of secure data environment. So it's important to realize this is a very big difference in approach. So in principle, data won't leave the NHS jurisdiction, and the long-term aim is access only via SDEs. Now, the potential upside, if you believe what the document says, is that the rules governing all of this use of data are going to be streamlined to take account of this new framework. And the document states that the aim is that the researchers will see improvements as each of the access committees adopts the same principles, and you'll get harmonized data access, templated access agreements, and everything will be much, much smoother. So this is the guarantee, and it sounds this sounds plausible and sounds good. And it might start to convince us that, and particularly the thing I was worried about before I saw this was that the government were just going to try and move us to this system, and then we'd have a whole load of stranded resources in academia, because from now on you wouldn't actually be able to get the data out. I'm somewhat reassured by this statement, because it goes on to say that the transition is going to be phased. They won't turn off data sharing overnight, and there'll be a period of dual operating. So it seems like the first good thing is that there's not going to be any sort of cliff edge to this, and it won't suddenly go to a stage that is shown only access via this route. And the second thing that's really good is that it actually seems like trial sharing for clinical trials. So a lot of the sort of thing that I do, and many of us here, I think, do, is not going to be effective if you were already running a consented volunteer or a consented trial. Then you'll still be able to do that, and you won't have to store it in an SDE. You can carry on as you would before, but you might want to use an SDE. So it seems like that's good, and it's not telling us that we have to shift away from storing within academia to only storing within the NHS. So I think, broadly speaking, if the government, whichever colour, continues along this path, I think this is quite positive. So just one quick slide as to what we're trying to do, or at least the sort of thing that I'm trying to do. I see an SDE or our XNAP or whatever as sitting at the center of a sort of flow diagram and a sort of data life cycle that allows us to conduct multi-center trials with as much ease as we can. At the moment, we're taking data from multiple hospitals, bringing them into our XNAP here in the center of the process. If an SDE comes to occupy this space, that will be great, and we'll be able to do the same thing entirely within the NHS. We've seen this already, but I just wanted to emphasize that we're currently trying to write 2 courses, as I say. In academia, we've got tiers here, which all essentially will be implemented by academic systems, but we also want to be active with installing our software and doing our stuff within the TREs. And that's really one of the things I want to show you how that sort of flow process works between the NHS and academia in our own system. So this is the RMH system, how we try and work it in both worlds. So our data start out here on the modality, or in PACS, or indeed our hospital VNA. So the first place that they go is our XNAP identifiable system. This is entirely within the NHS, behind the firewall. And so data can get there either by a push, a routine push by the radiographers from the modality to here, or we can push from PACS to there, or we can actually start out here and pull the data from the VNA. So that's the case where all our data end up on a research machine. It's not quite big enough to be a shadow PACS or anything like that, but it's a research machine where we can pull study-related images. So we can then run some pseudonymizations, and that pseudonymization goes in one of 2 directions. It either goes into the Royal Marsden trusted research environment, so that's still completely housed within the NHS, but the data are all anonymized, and people can connect via appropriate authentication to that from outside. So it's designed so industry can come in and run studies on our anonymized image data. Or just by flick of the switch, if you like, you can change the destination to our academic anonymized platform over here. And so we then do an appropriate level of anonymization in each case, and then potentially we then do more anonymization and more quality control if we want to go up the tiers to something that's more permissive and more widely shared. And we do even have a machine for open access, but we find we very rarely are interested in producing data that we will let to go entirely open access. So here's just a quick detail of the trusted research environment that the RMH have. So I would go to I go to my Iridia web login, enter my email address and password, usual 2-factor authentication, and then I get access to this. This is our Iridia workspace, and then once I'm there and authenticated, I can start up a virtual machine, and on that virtual machine, I've got XNAP running. So this is my XNAP software, just the same as I would have in the academic environment, except now it's the one that has a back end of a server that is on the trusted research environment. And then I can view images and do all my studies in exactly the same way. So it's completely seamless, and effectively it just depends. What platform do I choose to log in on? So I log in on that. The XNAP experience is exactly the same. I just see a different set of data depending on which data have been sent to which tier of structure. And this I just put in very briefly to show you how our in-house anonymization works. So I'm going to show you how we do a typical data retrieval from the VNA. So I would first, again, all this can be done via my web browser on my desk, whether I'm at home, whether I'm at work, or wherever. So I go onto the Royal Marsden's website. I authenticate using their usual two-factor authentication. I then boot up the virtual machine on. So this is a Royal Marsden virtual desktop. This is my XNAT running here. I log in, and then XNAT has a really nice tool called DICOM Query Retrieve that I can insert a spreadsheet of IDs or identifiers that I want to retrieve. I pull them off packs, and then I can then those data end up in XNAT. Once they're in XNAT, we have a pseudonymization scheme where the first thing we do is we choose a source. I'm sorry, the text is really too small to read here, but it said the source is my identifiable XNAT. The destination is my anonymized XNAT. So I choose source and destination and the projects where the data sit on each. And then I define the filter to say, I only want to send MR data, and I want to automatically filter out these pesky secondary capture images, these radiology reports, etc. So I choose what I want to send. I then go to the next screen. I'll choose the patient, and again, this is too small to see. Now I click transfer, and then it's done, and I can queue up 10, 50, however many patients I want, and just click transfer once, and they all get transferred and de-identified. So that's the internal flow, and that's really easy for us to control. The flow in from outside is slightly more complicated because it involves other trusts, and I talked about that this morning. Okay, so bottom line, benefits of NHS versus academia. So I think if you want to do stuff within the NHS, it probably requires more time and effort to set up your data archiving platform within the NHS. You might have more committees to gain permissions from. Installing physical infrastructure within an NHS institution is not necessarily the most straightforward thing to do. You've got to get all the firewall permissions sorted. You might have hiring the staff within the NHS to do this sort of stuff is not necessarily easy. And permissions to install and or manage, as a researcher, my permissions that the NHS might give me to manage my own platform, might be limited. On the other hand, for purely internal research studies within the institution, if you don't need to share data with any other organization, it might make it easier to start off your studies if you don't have to worry about exporting it beyond the NHS firewall. And of course, you've got the potential, if everything goes well in your institution, you might be able to use these data directly to deploy a proof of concept platform into the clinic. So that's all good. The benefits in academia are probably all the inverses of those. And crucially, you might get more freedom. You might possibly get more state-of-the-art infrastructure. And possibly you might get more flexibility for different people to input data to you if you're in academia and rather than the NHS. Briefly, cloud versus on-prem. So this is quite an awkward one. It looks as if by the amount of red in there, it seems like I'm really down on cloud. It was very interesting. I tried this because I had to set up a little service for myself, just do a little bit of research, and I just couldn't be bothered to go through the ICR's route, so I just set it up with my credit card, and it was my own private research, so I didn't involve anybody else's data. I literally managed to set up my virtual machine as Google helped us that, but I mean, in 5 minutes it took me to go through this, and I had the virtual machine up maybe in 10 minutes. The same exercise to set up something properly in the NHS with Azure took me 18 months. And I'm not saying it's the exact comparable situation, but there's a lot of stuff that you have to do if you want to do this properly. So the good things about this from an NHS point of view, responsibility for platform integrity can be completely devolved to the supplier, and it's much easier to spin up new machines once you've got the agreement in place. On-prem has disadvantages. You've got to set up server space. You need lots of local expertise. You potentially get more bang for your buck in terms of hardware if you buy it all in yourself and don't need all these extra services. But it's much slower to add new capacity, and you have to take the responsibility for it if it goes wrong and sort it all out. So there are different advantages and disadvantages. So conclusion, 10 years ago, it would have been really difficult to do any of these large-scale studies in the NHS. You would have had to go to academia. Nowadays, it isn't. There's the potential exists to do some really cutting-edge studies within the NHS, and UK policy is pushing us to do more work there. I don't think there's any threat immediately, so maybe next 3 to 5 years, to our traditional sharing model of clinical studies. And equally, both NHS and academia have their own advantages and disadvantages, and the same is true for cloud. It's very much find out what your study needs and then decide where you need to. So thanks very much.